Thank you. So first I want to thank the organizers of this great summit. It's been a fantastic experience for me. I think that I am learning at least as much and probably more than I plan to tell you. So I'm making out. I hope you guys are liking it too. Anyway, we are going to shift gears. I am a clinical cognitive and behavioral neurologist, so much less talk about mechanism. It'll also be something of a smorgasbord talk because in recent years, we've seen a real explosion of interest in clinical applications of tDCS. And really, there are far too many for me to try to address all of the ways in which clinicians have tried to use this technology in the last few years. So I'm really going to cherry pick a few topics that either I do some work in, or I'm interested in, or I think seem especially promising. So I have nothing to disclose. I really should learn to be more entrepreneurial about this. All right, so the way I frame this is just by asking a few core questions, all right? Literally the who, what, where, why, and when about using tDCS clinically. So let's start with why. Why would you think to use tDCS in a clinical population? So we'll spend some time thinking about why it might be a good therapy, what are some of its advantages, and then we'll talk a little bit about the where and how. How do you go about stimulating a patient? What kinds of parameters would be important to think about? You've already heard about them, but we'll sort of recap that. And then we'll get to the heart of our discussion, a little bit of what, right? What diseases are of interest to us, at least at this time. And here I'll focus on, like I said, I'm cherry picking a little bit. I'll focus on 4 areas in particular: cognitive remediation, and I'll sort of extend that to cognitive enhancement a little bit, although we'll have another talk about that a little bit later in the day. And that'll link intimately with cognitive neuroscience as well. We'll talk about tDCS to manipulate different cognitive domains. And then we'll focus on stroke recovery and a few particular kinds of deficits within stroke and what tDCS is being used for. And then I'll just say a couple of words about chronic pain and depression because those are a couple of areas that there's been some rising interest using tDCS. And then finally, I just want to touch very briefly, as a clinician who has individuals emailing him and calling him and sometimes texting him, asking if they should get tDCS, all right, to improve various aspects of either their dysfunction or increasingly their normal function, I want to talk a little bit about the who of tDCS. And this sort of enters into clinical ethics. Who gets stimulated and who stimulates these patients? And so we'll talk a little bit about that, especially as self-made or do-it-yourself tDCS is becoming more popular. All right, so first, our rationale for tDCS as a therapy. Well, there are a number of reasons one could choose to why one would want to use tDCS as a clinical therapy. First of all, you've heard a lot. I'll recap in just one slide, but you've heard a lot about the relevant mechanisms of action. Right? There are very good reasons to believe that it's doing a lot at the neural level, and so we first of all believe it does something. Secondly, there are a lot of practical advantages with respect to clinical implementation, and also those practical advantages afford some flexibility with respect to clinical approaches. So without belaboring this, because you heard 2 talks really touching on this topic in detail, there are a number of mechanisms of action tDCS that have been observed or speculated that give us confidence that it has activity at the neural level that can be translated into clinical applications. So you've heard a lot about how it modifies the synaptic microenvironment, and we've touched on how it induces what we think are LTP-like effects in neural systems. It may have other prolonged neurochemical changes, and we actually heard a little bit about how it has complex interactions with other neurotransmitter systems. And then we did hear from Michael Nietzsche a little bit about how the effects of tDCS are not only local, not only at the site of stimulation, but there are also connectivity-driven remote effects. So you're not just stimulating at the site where underneath the pads, but you're stimulating other areas that are connected to them through synaptic connections or through entire networks of neurons devoted to specific operations. And then One thing that wasn't really touched on, but has been discussed a little bit in the literature, is that there's a potential for non-neuronal structures to be affected in ways that might affect neural activity as well. So, for example, electrical effects on vasomotor tone in cerebral blood vessels, that kind of thing, which hasn't really fully been explored to the point of understanding how it affects things, but is another potential mechanism. So, now that we have the sense, you've had sort of 2 hours to get your head around the idea that tDCS really does something in the brain, and that something could really have a significant effect on downstream behaviors, let's talk a little bit about some of the practical advantages of the technology. First, I want to talk about its safety and its tolerability. Right? It is very well tolerated. It is very safe to date. No serious adverse effects from tDCS have been demonstrated in normal or clinical populations. And you can look at a number of safety papers with respect to this. I chose this paper primarily because we wrote it. And so this is in over 130 subjects, a little over 270 tDCS sessions. We had no serious adverse effects. All of the reported side effects were mild. They included, at the time of stimulation, tingling, itching, burning, a little bit of discomfort. They went away rapidly after stimulation, where subjects reported only the mildest of effects. Another advantage, just a practical, logistical advantage of doing tDCS, right, is that it's portable, right? I mean, it's if you were playing 20 questions and you were trying to guess at a tDCS unit and you asked the question, is it smaller than a bread box? The answer is yes, right? It's very convenient in that way. So that convenience lends itself to pairing with other therapies, right? So once you have the unit strapped to your head, you can pair it with other therapies like occupational therapy, physical therapy, speech therapy, different behavioral and cognitive tasks. And so in those ways, it is quite amenable to sort of co-intervention. And then, of course, the price point is right. The costs range from the hundreds of dollars to, if you get sort of the unit with all the bells and whistles, I mean, we're really talking about in the thousands of dollars, but not too much more. I mean, relative to medical technologies in general, this is a very inexpensive device. And for better or for worse, it can be implemented without advanced medical training. Right? I mean, we can ask Marone, building the next generation of units might be rocket science. Turning on this generation of ones and using them is not. And so in that way, it has a number of practical advantages that lend themselves to its clinical implementation. So we can think about using tDCS in two sort of categories of ways in clinical populations. The first is as a type of replacement therapy. And by that I mean that there may be some kinds of treatments where the side effects of whatever medication you're taking are intolerable, or we talked about how inexpensive, portable, and accessible the technology is. It might be the case that the standard of care therapy in a particular place, say someplace in the developing world, may be unavailable or perhaps too expensive to implement. Well, a device as portable and easily applied as tDCS can actually stand in that situation. But the more common way in which tDCS ends up being explored in clinical populations is as a type of augmentation. That idea being that it can be used to enhance the efficacy of existing therapies, whether those therapies be medication therapies or some type of behavioral treatment that can be paired with stimulation. Just to talk a little bit, and you've heard, in our first two talks, a lot of introduction about this point, so I'll just touch on it briefly, just to talk a little bit about the parameters that would be relevant for a clinical study. I think one of the first and most important of them, if you haven't gotten this impression already, is the placement of the electrodes. And this might seem by now, two talks into it, like a self-evident point to this audience. However, if you look out in the literature as well as in the lay literature of individuals who are starting to apply tDCS to themselves, there's a certain indiscriminate quality with respect to how specific mechanisms, what type of cognition or what type of mental operation one is is trying to manipulate or what type of function one is trying to manipulate with respect to where one is putting the electrode. So the first point is that electrode placement counts. Right? So just as an example of this, these are two papers from our lab. And really, the only point here I want to demonstrate is, and this is modeling done with Mérome's help, is that placement of electrodes really has an effect on where we think the current is distributed, right? So here is placement of the electrodes over the dorsolateral prefrontal cortex for the cathode and over the mastoid on the opposite side for the reference electrode, yields us this distribution of current. Compare that to placement of the anode and the cathode over the bilateral temporoparietal junction, and it just yields us a different estimate of where the maximal current is. And so, it really does seem to matter with respect to where you put your electrodes, including, and we've touched on this point a little bit already, the reference electrode, right? This oft neglected electrode that can be placed either extracephalically, so sometimes it's placed on the shoulder or behind the mastoid, or the other electrode is sometimes placed over the forehead. Very common montage to place the electrode over the forehead, and there's evidence to suggest that the estimated distribution of current varies pretty strongly depending on where you place that reference electrode. So the first point in terms of clinical parameters for stimulation is what is it that you're trying to manipulate, and where are you putting your electrodes to get there? I'll also say, and also using another set of models from Mérome, that electrode size matters. Right? This is actually a paper of his from a few years ago. What it demonstrates is there's sort of two different sizes of reference electrode placed over the supraorbital space, and one very large, one very small. We sort of talked about this with Nietzsche in the first talk, that it makes a big difference with respect to where we think the current is distributed, right? And so electrode size, electrode distribution, those placement, those things are really of critical importance. And then, of course, I think it goes without saying that the intensity of stimulation is a core parameter that needs to be addressed. And it's one that I think is being explored. It needs to be explored in a somewhat more nuanced way. We heard in our first talk, and just to emphasize it, that the effects of stimulation at one intensity, the relationship between effect and intensity may not scale linearly, right? So the effect that you expect at 2 milliamps with an electrode of a certain polarity might not just be an exaggeration of the effect that you received at 1 milliamp with the electrode of that polarity, right? So that's a second dimension that is critical to think about in these kinds of studies. And then, of course, it goes without saying how long you're stimulating and then how often you are stimulating. We've touched on this point as well in our mechanisms talk, but the one thing I'll say is that for clinical purposes, it is pretty clear that multiple sessions, if you're trying to induce some lasting effect in a clinical population, it appears to be the case that the studies that really really induce that kind of enduring effect have multiple sessions of stimulation paired with some type of behavior typically. All right, and so as I told you, the placement of the electrodes is important. Having some understanding of where we think the current is going, right, is important. And so that underscores the growing importance of having some type of way of predicting. And one technique that is emerging, I think with a growing number of clinicians who are interested, or clinical researchers who are interested in tDCS, is to model these kinds of current flows. And so, again, this is work that Mérome has been very pivotal in. So I'm just showing another one of his slides. And so what it demonstrates here is that you can estimate the flow of current between electrodes, and again, it can be used to predict where you're going. But also what's illustrated here is that with conventional stimulation, you can often have a distribution of current that is much more distributed than what you might have anticipated if you thought that the only place where you were going to receive maximal current was under the pads, right? And so here, for instance, in this pretty typical montage of one electrode over the motor cortex and one over the frontal pole, you've got this distribution of current, which is bilateral, right, and is sort of a swath across much of the frontal lobes. And so, not to, again, sort of point to work that someone else is doing here, but in the same room, there's development underway of these high definition tDCS systems. And so as someone focusing on the clinical aspects, I would be remiss if I didn't mention that systems are underway or being used, implemented, that really aim to focus stimulation in a much more spatially, in a way that has higher spatial resolution. All right, so let's shift gears now. Stop talking about why tDCS is so great to use and how we should use it, and talk about what it is that we are starting to use it for. And I want to start by focusing on studies in cognition, because I think that tDCS is one technology that has allowed cognitive neuroscience to have a much more translational bent, studies of cognition that actually end up having practical clinical implications. And so here I'm going to focus on just a few of the many different types of cognitive studies that have been done using tDCS, and I'm certain you're going to hear about more later. I'm going to focus just a little bit on language, learning and memory, mathematical reasoning, and executive functions. So in the domain of language, there have been a number of studies using tDCS in healthy individuals that have some degree of applicability potentially to clinical populations. So they include improved acquisition of novel names. So you make up generate novel names for objects. You teach individuals those names, and it turns out that individuals getting stimulation over the perisylbian language circuit will acquire those names more robustly. The same with a novel grammar. So what's illustrated here in this figure is a study in which the investigators created a new grammar, taught this new grammar to individuals, and they were getting left hemisphere stimulation. And what they found was that after they were learning with tDCS, they were better able to detect errors of the new grammar, right? Grammatical errors in this new grammar they had never known before when getting tDCS compared to sham. Also, tDCS has been used to increase verbal fluency. In our lab, this is work a couple of years ago from a fellow at the time who's now a faculty member at Georgetown, Peter Turkeltaub. tDCS has been used at least transiently to enhance reading ability. So this was a study in which we studied normal subjects, and they received anodal stimulation over the left. This is the posterior temporal cortex or temporal parietal junction, however you want to think about it. Cathode over the right. And what we found was that they had an increase, these are again normal individuals getting tDCS, in reading efficiency on standardized measures of reading. Right? And so these were, again, healthy individuals. This is an area of the brain that's been implicated in visual word form recognition and in the ability to read. And so we're able to manipulate this in a way that we think might have some applicability down the road to populations like individuals with developmental dyslexia. This was a study that was alluded to a little bit earlier in the session today, a study by Reese and colleagues involving motor learning. And here, tDCS was applied as subjects were learning this complicated motor task. They had to sort of play this little video game with a force transducer where they would squeeze and the little sensor here or the little indicator here would jut out depending on how hard they squeezed, and they had to sort of go in a very complicated pattern, maybe 2, then back, then 1, then back, then 3, then back, so they had to learn this very complicated task. They used TMS to identify where the motor cortex was and then stuck tDCS there, right? And after 5 days of training, they acquired the skill more rapidly than subjects who received sham. And after about 3 months of testing, right, this is day 85 out here, right, they still had acquisition of this or retention of this motor skill better than subjects who had received sham tDCS. So again, work in normal populations that points to work that could be done in the reacquisition of skills in patient populations. I'll focus for a moment on a couple of investigations that look at frontal lobe functions, because there are a lot of patient populations with cognitive deficits where we think that some intervention on executive function and frontal lobe abilities could be useful. One that I'll focus on first is, again, for our group, and it involves mental flexibility with common objects. So what we asked the subjects to do here was to provide novel uses for common objects. Right? So, for example, you would see this object, right, this very clunky-looking shoe, and a person might say, well, if you made me think of something new to do with that, I might use it to hammer in nails. Right? I'm going to use it as a hammer. Okay, great. So what we did was we actually inhibited, or we used cathodal tDCS over the frontal lobe. And what we found was that using cathodal tDCS actually decreased the response time. Individuals were able to respond more quickly as to what alternative use they would come up with for this kind of object. And moreover, they were much less likely to default. In other words, a number of times when you're asked to come up with an unusual use for a thing that you're very used to using one way, you don't come up with anything. They're much less likely to actually default on that answer than individuals who had either gotten anodal stimulation there or sham stimulation there. So we thought that it had some impact on their mental flexibility. In fact, that perhaps inhibiting that region sort of freed them of a certain amount of cognitive control, allowed them to think more flexibly. Another area, again, focusing on frontal lobe functions, where I think that there's a lot of potential for a future clinical purchase for a tDCS, is in appetitive behavior. And that can include things like cravings and potentially down the road things like addiction. So this is a study. I realize the print is really small, so I can barely read it myself, but I think you can all see that the lines separate quite nicely. This is a study of food craving. So this is 19 subjects. They were asked to evaluate how much they were craving certain foods. They were reporting food cravings, and then they got stimulation over the frontal lobe, and they reported both during stimulation and after stimulation that they felt like that craving was somehow diminished, that their ability to control their own behavior and resist if that food were to be presented to them was somehow increased. And this is one of a family of studies. The reason I chose it is because, well, it's such a ubiquitous issue, right? I mean, imagine if we had some way to diminish the degree to which we crave unhealthful foods. But also sort of touches on a broader topic of appetitive behavior that can be modulated using this technology. And then some work that really garnered public attention and sort of caught the public eye a couple of years ago, and there's been some work extending it with transcranial random noise stimulation, was Roy Cohen-Kodash's work involving what he referred to as numerical competence. And this will take a little bit of unpacking the actual way that they did this study. So this has to do with how people process number concepts. And so what this group did was they taught individuals a certain set of symbols. The symbols were previously meaningless. Right? And so what they taught them was that these symbols have a relationship to one another. So this squiggly shape that doesn't look like anything in particular is greater than that squiggly shape, is less than this squiggly shape, is greater than this. Right? They all have this ordinal relationship. And stimulated them as they were learning these relationships in two different montages versus sham. And then what they found was when they subjected these individuals to two behavioral tasks, the individuals who got stimulation with right anodal tDCS were more likely to think of these objects that they had been taught these ordinal relationships to think of them in number-like ways. And so the way they explored that is that they had what was called a number Stroop task. So these numbers would appear, or these shapes would appear side by side, and they might be mismatched in shape. Right? One might be bigger than the other smaller. And so what they did was they either had congruent trials or incongruent trials. In congruent trials, the bigger shape was actually the shape that had the bigger value that the subject had learned. Right? In the incongruent trials, they were mismatched, so the bigger shape had a smaller value. And so as individuals sort of took on or understood the value of these things, it generated an incongruency effect. It took them longer to respond if the size of the object and its value were mismatched. And what they found is that tDCS could enhance that idea that these items have these specific values, right, by enhancing this interference effect. The second way they looked at it was, and this takes a little sort of discussion as well, a little explaining, it turns out that when we're sort of early on, before we've really formed very strong number concepts, we don't tend to think of numbers or allocate them in an exactly linear way, the way that we do when we sort of acquire these concepts really well and understand them. So if we make a number line, you or I all understand that 1 is equally distant to 2 as 9 is to 10. Well, it turns out that small children don't necessarily do that before they sort of solidify some of these number-space relationships. And so what they found was that individuals who had not benefited or had the montage that didn't work, so left anodal or sham, they had this nonlinear relationship with these objects when they were asked to put the numbers or put the objects in a line by value, whereas the individuals who had received stimulation sort of put them in a linear order, the way we do when we understand things to be numbers. And so there was sort of indirect evidence that these individuals were taking on a sort of more number-like concept with stimulation of the parietal cortex. All right, so then focusing, again, shifting gears a little bit, focusing on post-stroke rehabilitation. There have really been 3 areas in which tDCS has been applied, and we'll touch on them briefly. Paresis, visual spatial neglect, and aphasia. And so in all 3 of these, I want to introduce this concept that's going to come up several times, and that's the notion of interhemispheric interactions and interhemispheric inhibition. So this is an idea that dates back, actually, depending on what kinds of deficits you're talking about, decades. But it's the idea that normally, in the normative state, we obviously have a lot of connections running between the 2 hemispheres, many of them through the corpus callosum. Well, it turns out that physiologically, many of these connections are inhibitory in nature. And so the way this model, the way this theory goes, is that if you have a unilateral lesion, one hemisphere obviously is not functioning as well as it had. The other one is intact, but in addition to being intact, it's also released from inhibition, right, from the inhibition that it had been experiencing from its contralateral, now injured hemisphere. So with that being the case, the way this model goes is that there's increased inhibition from the intact hemisphere due to its increased activity to the injured hemisphere. And if you assume that there are perilesional areas of the injured hemisphere that are, in the process of rehabilitation trying to recover, if I can anthropomorphize them, trying to recover, you don't really want to add this added insult of transcallosal inhibition to injury. All right, so that's how that model goes. And so with respect to motor recovery, that engenders a few different approaches that you could take with respect to paresis. And so looking at a few studies over the last 7-8 years or so, there have been a number of studies where the principal approach has been to excite the damaged hemisphere, right, using anodal stimulation. And we can sort of go back and forth about whether or not that's the right way to frame what anodal versus cathodal stimulation are really doing, but according to our conventional thoughts about tDCS, that anodal stimulation can increase the activity of this hemisphere. And so there have been a number of studies, both in chronic and subacute populations, that implement tDCS in that way. But there have also been a number of studies that take the opposite approach. Right? Let's tamp down the extra excitation, the pathological activity of the right hemisphere to diminish its interhemispheric inhibition. And so there have been a number of studies that have looked at using cathodal stimulation and sort of tamping down activity in that hemisphere in order to allow for perilesional areas of the damaged hemisphere to recover. And then finally, one of the advantages of tDCS over TMS is that you can actually apply bilateral stimulation. Right? So you can have a cathode and an anode, so why not leverage that? So there are emerging studies, a few in the last few years and more recently, looking at doing both, applying anodal stimulation to the ipsilesional side and cathodal stimulation to the contralesional side. I just want to focus on one more recent study. It came out this year, in part because it has many of these studies are small in terms of their patient populations. This is a slightly larger one, but also because it was one of the first to directly compare anodal stimulation to cathodal stimulation of the contralesional or intact hemisphere to sham. And just looking at the results in this subacute population followed out to 3 months, again, this is another one of those sets of graphs where it's too small for you to actually read it, but the lines dissociate. So you can tell the point I'm trying to make. Anodal stimulation of the ipsilesional hemisphere, the damaged hemisphere, and cathodal stimulation of the contralateral hemisphere up here. Sham stimulation is down here, right? And in pretty much all cases. And these are various measures of motor recovery, of motor strength, hand grip, both in the upper extremity as well as in the lower extremity. And then there are a number of stroke scales, clinical stroke scales. Same story. You can't read these, but just follow the dissociation. Sham's down here, right? In this case, higher is worse. So there's sham, and there's anodal and cathodal stimulation. Sort of alluding to the idea that there are multiple approaches that one could adopt in terms of facilitating recovery with tDCS. So let me, again, within the domain of stroke recovery, shift to a more cognitive deficit, and that is aphasia. And so I'm not sure how many of you are familiar with aphasia syndromes. Yes, sir.
Can I ask one question on
Yeah.
the previous slide? Has anyone shown that bilateral anodal cathodal also works?
Yes. Yeah.
Okay.
So there are.
Because there are negative findings out there as well.
There are. So there are some mixed findings with respect to bilateral anodal cathodal stimulation, but there also are some positive. I mean, as you know, it's a mixed bag. So it's something that people are exploring more. Okay. It's one of those things that it's. Now that we sort of stopped to talk about it, it's sort of interesting because on a theoretical basis, if this model was strictly true, you would expect that it would be the montage that would give you your most bang for the buck. Right? But that hasn't really sort of borne that much fruit yet.
Okay.
All right, so for those of you who aren't clinically familiar with aphasia, I just wanted to say a word about it. It's an acquired deficit of language. In the context of stroke, it actually affects about 1/5 of patients who have stroke. And stroke, whether you may or may not realize, is the #1 cause of morbidity in this country. It's the #1 cause of disability. So we're talking about something that's causing 1/5, it's present in 1/5 of cases, this disease that's the leading cause of disability. It affects about 1 million people in this country, about 100,000 new patients annually. It usually results from injury to a left perisylvian circuit, so the left hemisphere. You can broadly categorize stroke deficits according to lesion location, where more anterior lesions often engender a non-fluent aphasia, when patients have poor grammar, slowed speech, that kind of thing, and more posterior lesions of the sort of more posterior temporal lobe typically engender more fluent aphasias, where comprehension is often affected. And as I said, it's a very common cause of morbidity. So in thinking about aphasia, this idea of interhemispheric interactions again comes into play. You can imagine several ways in which one might apply tDCS in order to try and facilitate language recovery. So if you have, normally a left hemisphere perisylvian circuit that's functioning to subserve language, after injury of that circuit, there's some thinking that perilesional areas of the left hemisphere compensate, that they sort of take on some of the function of damaged left hemisphere areas, in which case you would think that your optimal strategy would be to try and enhance activity of left hemisphere perilesional areas. Skipping over this figure for a second, over here on the far right is that interhemispheric inhibition model I've told you about, right? So you can imagine that in addition to these areas, these perilesional areas struggling to do their best to recover from aphasia, that they are also receiving deleterious interhemispheric inhibitory inputs from regions of the right hemisphere. Well, according to that model, an alternative approach that you might consider taking might be to actually apply some form of inhibitory stimulation, right? Maybe cathodal tDCS to that hemisphere. And then finally, maybe it's the case, and there's certainly evidence from functional imaging and behavioral evidence as well to suggest that this might be true, that right hemisphere areas aren't necessarily all bad when they have increased activity in the setting of stroke and aphasia, and that maybe they play some compensatory role. So in that case, you might actually be interested in taking the opposite approach, right? Maybe you want to facilitate activity of the right hemisphere. For instance, perhaps, just theoretically, if
left hemisphere lesions are especially large. There's no perilesional area to speak of to actually try and enhance. Maybe it's the right hemisphere that's trying to do the compensatory work with respect to language. And it turns out, corresponding to these various theories of how aphasia recovery might work, that there are a number of studies that address this in both hemispheres. So basically that each of these approaches has been attempted in clinical populations. So that includes anodal stimulation of left hemisphere, right, with the idea of getting these perilesional areas more excited. Cathodal stimulation of the right hemisphere, anodal stimulation of the right hemisphere. Basically, all of these different approaches have been tried with for each of those montages at least some evidence of efficacy, although not universally positive evidence. And again, the point of this is not for you to read it. I'm just putting it up there to show that there have been a number of different studies, but I'll also highlight that there are a number of limitations. So the limitations, just to highlight them, again, not for you to read, but for me just to point out that they generally have small samples, these aphasia studies. I mean, we're talking mostly single-digit patient studies. The clinical syndromes that these patients have are very heterogeneous. So remember I told you that there are non-fluent aphasias, there are fluent aphasias, some patients have both, they have global aphasias. So many of these studies will involve multiple different types of aphasia subtypes, as well as lesion locations and chronicities, subacute versus chronic aphasia. There's also variability in stimulation parameters that may be coming into play. And so as we just talked about, both in our earlier talks and today, it turns out that the stimulation parameters may have, like intensity, may have a dramatic effect on what kind of neurophysiologic effect you're expecting, and consequently, potentially, what kind of behavioral effect you're expecting. And then what I think of as one of the real limitations of any rehabilitation study that doesn't have it is good follow-up, right? So only a handful of studies in aphasia, and I can actually extend this into the motor domain as well, actually follow these patients out for any considerable length of time to see if these benefits that they experience are persistent. I can't leave this topic without showing at least a little bit of some of the data that we're collecting in our laboratory right now using tDCS in patients with chronic aphasia. So this is a protocol where they come in, they get stimulated 2 weeks in a row. These are 2 5-day weeks, and then we follow them out months afterwards. It's sham controlled. It's a partial crossover study, so the sham subjects end up getting stimulated. And what we find is that they have improvements in, these are all non-fluent patients, improvements in measures of aphasia. So this is the Western Aphasia Batteries Aphasia Quotient. So it's an overall summary of the severity of aphasia. And they do show, well, I don't know if you want to call it modest. I mean, here's the scale here. They're sort of moving within aphasia category, but moving a fair amount within aphasia category compared to patients who are receiving sham. One point I'll point out, and I wasn't, and here's another way of displaying the data, which makes it look a little bit rosier, right? This is a percentage change in the Western Aphasia Battery Quotient for patients getting real stimulation versus sham stimulation. And you see the sham patients really get nothing, and the real patients appear to be benefiting. One interesting point I'll point out about our work here is that it turns out that the way we do this study is that we're agnostic to which of these mechanisms is at work for each of these patients. So we literally bring them in, and on different days of the week, we'll stimulate them anode left, cathode left, anode right, cathode right, and have them perform a naming task that day to see if there's one particular montage for each patient that may benefit them the best, right? And so patients are being stimulated in whichever their optimal montage is. One interesting point is that we actually find that a number of our patients, while it isn't necessarily their optimal montage, will actually respond to cathode of the left hemisphere, which was not something that we had expected, but we do stimulate at very high intensity, 2 milliamps. And so one interesting finding from the talk we had this morning is that stimulation of different intensities might actually have different effects. All right, you've seen this slide now a few times over the course of this summit. I just wanted to make the point with respect to aphasia, that conventional stimulation may give you this wide swath of effect. That's poor spatial resolution. And you'd think that that would be a drawback in this kind of research, but maybe it's not. Maybe for our purposes, it's a kind of advantage. So this is a meta-analysis of functional imaging work that we had done some time ago on studies involving non-fluent and fluent aphasias, patients with chronic aphasias compared to normal subjects. And what they demonstrate is that, I don't know if you could see these areas of activation, but patients with aphasia activate a bilateral network of regions when they're trying to perform language tasks, at least when they're in the chronic state. And so one thing we think is that perhaps the so-called disadvantage of spatial resolution in tDCS, when you're trying to hit a broad network of areas that subserves some remodeled cognitive function like language, may actually be an advantage. Finally, a couple of studies have looked at the effect of tDCS in neglect. For those of you who aren't familiar with clinical neglect, it actually affects about 2/3 of right hemisphere stroke patients acutely. So it's very, very common. It is the failure to report, respond, or orient to meaningful or novel stimuli that are on the opposite side of space as where you had your brain injury. It also tends to be a lateralized function. So whereas language tends to be lateralized to the left hemisphere, it's almost always the case, it's usually the case, that neglect is associated with right hemisphere lesions. It's a terrible prognostic indicator. Pound for pound, you are worse off having neglect as a persistent deficit than you are having hemiparesis. And so, again, this is another example, since it tends to be a unilateral injury that gives rise to neglect, or at least a lateralized deficit, of where stimulating perilesional or interhemispherically can have effects. And you can sort of bring in that model that I showed you with respect to paresis and aphasia to this paradigm as well. So there have been studies, really just a handful, I'll show you a couple, in which anodal stimulation of the right parietal cortex, and I should mention that lesions of the parietal lobe are the most common lesions associated with neglect, have resulted in improvements in measures of neglect function, or visual spatial function. This is line bisection. This is a task where individuals are shown lines. They're asked to cut them in half, right? And so the patient who's neglecting half of space skews away from the middle, right? So you can actually correct that to some extent by applying anodal stimulation of the right parietal cortex. A later paper, slightly later paper, demonstrated that contralesional, anodal, and ipsilesional, cathodal contralesional and anodal ipsilesional tDCS can actually improve performance on that task. So again, inhibiting, or at least we think potentially inhibiting the intact hemisphere as well as stimulating the damaged hemisphere. Again, sort of speaking to those interhemispheric models we were talking about. In our lab, we've been exploring whether or not transcranial direct current stimulation can be used to try and fractionate different types of neglect symptoms. Now, this study happens to be in healthy subjects, but it's inspired by our interest in applying it to patients with neglect, so I'm presenting it here. Because we think we can apply it to patients in a symptom-specific way. So when a patient is neglecting, they often have dissociations in what their neglect is like. You can have different neglect subtypes. So some patients have what's called egocentric neglect. They neglect with respect to their own body's frame of reference. So they neglect things sort of to the left of their space. And then there are other patients who actually have what's called allocentric neglect. And this is actually a copy drawn by a patient, an example of allocentric neglect, where their neglect is tied to the things that they are looking at. So as they look at things, they ignore the left side of the thing. Okay? And there's been some speculation that these might have different neural substrates. So we had a study in which we showed normal, healthy subjects an array of targets, and they were supposed to detect a target. And the targets could either be on the left side, well, it was a combination. The targets were sort of left and right side of space relative to them, but also the target itself on the object. The thing they're looking for is that gap. That could be on the left or right side of the object. All right, so both sort of an allocentric component and egocentric component. We stimulated over the parietal cortex. We did a baseline block and then followed them up after stimulation and found that we had a dissociation where there was much more of an effect on allocentric processing, that individuals were more rapid to respond to the location of that target on the left side of the object, even when that object is on the right side of the field, right, they had this accentuation of allocentric processes. So one thing that we're looking into is whether or not we can sort of fractionate these deficits and apply them to patients in specific ways. Just a slide on tDCS for pain. It's not an area of work for me, but I think it's a very interesting area of growth using this technology. There's some thinking, many of the studies that investigate this stimulate over the motor cortex, and the thinking is that there are connections between the motor cortex and subcortical areas like the thalamus, the cingulate gyrus, and other deeper structures that are involved in a sort of nociceptive network, and that by increasing that you can use the motor cortex as sort of an access point to connections to that network. And so just to highlight a couple of different pain studies, it's been used to decrease analgesia use in patients getting knee replacements, as well as patients who are undergoing ERCP. For those of you who don't know what that is, that's endoscopic retrograde cholangiopancreatography, and it's very painful. Almost as painful as it is to say. Anyway, so however, the results aren't universal. They're not unanimous. So, for instance, there's a recent study where it didn't seem to help for patients getting lumbar surgery. There are several studies now looking at its potential positive effects in fibromyalgia pain, chronic spinal cord injury, although, again, here the jury might still be out. There is some debate in the literature as to whether or not it's helpful. And then it's being explored more for migraine prophylaxis, both with this montage I was telling you about, stimulation over the motor cortex, as well as stimulation over the visual cortex. As you may or may not know, migraine sufferers will often have visual phenomena, visual auras, as some of the earliest symptoms of their migraine, of an oncoming migraine. And so it turns out that, at least in one investigation, cathodal stimulation over V1 was helpful in reducing migraine symptoms. Oh, and also chronic pain in patients with multiple sclerosis, and phantom limb pain, that strange pain that individuals who are amputees get, where they get that illusory sensation of an existing limb. All right, a few words about depression. How am I doing for that?
We have like 10 minutes.
10 minutes? I'm great. Okay, so a few words about depression. And I focus here. I actually think that the data for depression right now are pretty mixed. The reason I focus on this is that in terms of areas where non-invasive brain stimulation has found some clinical purchase, we know that depression is the only FDA-approved clinical indication for TMS. And so it's sort of an obvious go-to area with respect to clinical syndromes that we could stimulate with hopes of improvement. And so the most common montage that's been seen in the literature is anodal stimulation of the left dorsolateral prefrontal cortex. Interestingly, many of the studies that have been done have pointed not only to the effects on mood, but also to beneficial effects on cognitive performance, various aspects of cognitive performance that in my mind are sort of linked to the function of the dorsolateral prefrontal cortex, like working memory, aspects of attention, the ability to inhibit inappropriate responses on tasks, that kind of thing. And like I said, the studies are relatively few. Down here is an example from one of the earlier studies by Fregni and colleagues from a few years ago. And what this is demonstrating is improvement. The black is the subjects receiving tDCS, active tDCS, versus patients who are getting sham on a variety of different tests of executive function. The bars that really stand out here are digit span. So I give you a series of numbers. You have to give them back to me. Sometimes, in one setting, give them to you forward. You give them back to me. In another setting, I give them to you. You have to give them to me backwards. Sort of think of it as a test of executive function and working memory, and seems to improve in these patients who got stimulation. But like I said, I think recently, the weighted average of studies is a little bit mixed. I think the jury's still out, if I can just offer my opinion about the matter. So, for instance, a recent meta-analysis looked at all the randomized control studies of patients being stimulated for depression. And to make a long story short, found that the effect did not actually, the confidence interval of the effect did not sort of put it over the finish line with respect to an overall positive average effect. Now, you could sort of parcelate that out. It turned out that if you looked at the studies that looked at tDCS as a monotherapy, those studies seemed to be significantly better than sham. And we just heard earlier in the day about a study in which tDCS combined with the medication citalopram for the mechanisms that we discussed earlier might give more sort of bang for the buck or an extra boost. But I think the jury's still out, and it's an area of active investigation. So, yeah.
As far as the effect size and the variability, if you were to compare that, let's say, to where RTMS was before the big trials or even drugs, is it sort of what you'd expect, sort of, or?
Yeah, so, I think when we were looking at when early in the days of TMS for depression, you also saw, positive studies, some negative studies. A lot of the studies suffered from some of the same problems that studies in general in rehabilitation and treatment and tDCS now suffer from, like small sample sizes, variability in terms of the patient populations being chosen, variability with regards to the parameters. So, I suspect that we'll learn more, that the answer will become clearer as we sort of tighten up some of those parameters. So I think the short answer to your question is probably. So I just want to mention that I've sort of cherry-picked a number of topics, but I'm really scratching the surface. And it is my way of illustrating the fact that I'm scratching the surface on the various applications that people have been thinking about for tDCS. I'll just point to some of the studies that are ongoing that we're doing. If you sort of take that and multiply that by every lab that's studying tDCS, you can get an example or some idea of the various ways in which tDCS can be used. So in our lab, we're currently investigating whether it can be used to modulate executive dysfunction in patients with multiple sclerosis, whether it can be used to enhance speech fluency in patients with a degenerative type of aphasia called progressive non-fluent aphasia, whether it can be used to improve cognitive dysfunction in patients who are withdrawing from smoking as they're trying to quit. It turns out that when patients are trying to quit smoking in the period immediately after the onset of their abstinence, they have cognitive deficits. And there's some suggestion that if you can improve those, it actually improves their ability to abstain. And so we're looking at that. And some work that was actually initiated by Adam Woods, who's in the audience, is that tDCS can be used to modulate causal reasoning. And so we've taken that, and now we're starting to look at whether or not it can do so in patients who have schizophrenia, who suffer from deficits of causal reasoning, sort of cause and effect in their model of how the world works. All right. So if tDCS is so great and can be applied to all these different applications, why isn't it in common clinical use right now? Right? And so we already touched on a number of these points. tDCS currently has no FDA-approved clinical indications, and a lot of the studies that I've pointed to are at the sort of proof of concept stage, right? And that's not good enough to put something in clinical practice, at least in this country. The FDA has a clinical trial process, and before something becomes FDA approved for clinical use, it has to go through phase 1, which is safety, phase 2, efficacy, phase 3, sort of larger pivotal studies in both safety and efficacy, and there have to be 2 of those before it can be approved as a treatment. And that, of course, has implications for things like whether an insurance company will cover it, and so on and so forth. So, there are a number of steps to go through before tDCS becomes part of common clinical practice. Just to point out, there are some what I think of as surmountable hurdles, some of which have already been alluded to with respect to applying tDCS clinically. They include things, and I'm going to take it by phase, by study phase, dose effect curves. We talked a lot about how tDCS at different intensities, different durations, might actually have different effects. So that's something that needs to be fleshed out if you're going to introduce it as a clinical intervention. Also, the patient populations that we're talking about implementing tDCS in are at-risk populations, sort of by definition, and the safety of this technology, which we think of as very safe, hasn't really fully been fleshed out in these potentially risky populations, including populations, I should add, who are commonly taking those medications that affect neurotransmitters that we talked about having an effect on how tDCS works, right? So psychiatric and neurologic populations. Recruitment and eligibility are always challenges for clinical trials, especially using a technology that physicians and clinicians in the community haven't heard of. They might be reticent to refer their patients to get their brains zapped. And then we talked about the problem of heterogeneous patient populations affecting the interpretability of studies. A problem that we've sometimes run into is that these studies, I emphasized before that clinical studies by and large involve multiple sessions of tDCS. Well, it turns out that as a treatment, that can be a cause of attrition, that if subjects have to come in days in a row and then come in weeks after that to get it reassessed. And so that can stand as a surmountable hurdle, but a potential obstacle. And then any kind of study has control and blinding issues, although I think that that's better in tDCS than for some other technologies because it's more readily controlled with sham conditions. And then finally, we touched on this over and over again, the clinical approaches that have been used to date have been heterogeneous in their methodology, and it turns out that those parameters may have dramatic effects on what you're seeing in terms of effect sizes in patients. Last point, who should we stimulate? So it turns out that disease, especially with respect to cognitive complaints, cognitive deficits, psychological states, mood states, it falls somewhere on a spectrum. It can be a little bit tricky to decide where normal cognition ends and a diagnosable deficit begins. And I think a question that clinicians have to reflect on in a very practical sense is when am I giving a treatment to a patient, and when am I enhancing a cognitively normal individual? And does that matter to me, right, as a clinician? And here I think there are a number of things that have to be taken into account, irrespective of whether you feel like that's fine and all humans should have the ability to enhance themselves as much as they want, or whether you want to restrict yourself to patients. Something to consider is the risk-benefit ratio. Now, we talked about how safe tDCS is, but if we're talking about stimulating people with relatively mild deficits, there are at least theoretical risks. For instance, if we think that tDCS has sufficient enough to affect cognition in individuals on a long-term basis based on stimulation, it's unclear what makes us think that it can't have inadvertent effects on cognition. Right? And while that has not been demonstrated, I'm not saying that that's a imminent threat, it's at least something to consider and investigate. And then finally, I put in here that if we're talking about risk-benefit ratio and stimulating patients who are relatively modestly affected, many people out in the community are taking the kinds of medications that we talked about having variable effects on stimulation. And so as we sort of flesh out what those effects might be, it's worth sort of keeping that in mind in terms of who we're stimulating. And then finally, who should stimulate? All right, if you go on the internet today, if you go onto YouTube, you're going to find people who are stimulating themselves on camera. You're going to find do-it-yourself tDCS websites. You can find blueprints to build your own tDCS machine. You could go to Radio Shack with $100, come back home, go to your garage, and come out with a tDCS unit. And it's not controlled by the FDA, right? And there are commercially available units that you can get for just a couple $100. So the question arises, who really should be doing the stimulating? With direct-to-consumer marketing, it raises the issue, potentially, of public safety. At the very least, people might misuse it and burn their skin, things like that. But public safety in terms of whether it could be used inappropriately. Again, we talked a little bit about indiscriminate use with respect to electrode position, or overused, if that's a possibility. And while, like I said, we've said over and over again, it's a pretty safe technology as far as we know, we have to be cognizant of that possibility. On the other hand, we have to respect autonomy, right? I mean, to a large extent, we have the right to do a lot with our bodies and how we treat them. And so we have to have some respect for that. So that, in my opinion, is a potential source of future tension, sort of clinical ethical tension at least for clinicians, or career clinicians. And it'll be up to us to sort of sort out our fiduciary responsibility with respect to individuals who want stimulation. And that may branch out into the domain of public education about, well, how do you do tDCS safely? And maybe even public policy if it gets that far. So, to summarize, we've talked about the advantages of tDCS for clinical use, and there are many. It's safe, it's convenient, it's cheap. It has a variety of potential clinical applications, and we talked about these in some detail: psychiatry, neurology, physiatry and rehab, pain management, many others. I believe that cognitive neuroscience directly informs potential tDCS treatments, and we talked about a variety of different studies where you can manipulate cognition in ways that seem like they might down the road be applied to patients. There are some surmountable challenges, but challenges nonetheless to the development of tDCS as therapies that can be used widely in clinical settings. And we talked about that. And then finally, just touching on that ethical issue of cosmetic stimulation and self-stimulation, I think that it is an emerging, but not an insurmountable or inscrutable challenge for clinicians. So I want to thank everyone in the Laboratory for Cognition and Neural Stimulation, and I'd be happy to take questions.